Hi, my name is Mark Mullins, and today I'm going to talk to you about how I do teaching at the PACS. I don't have any financial disclosures for this talk. So first of all, starting out with logistics, in general, the way I like to do it is to utilize a web-based program to read out somebody, even if they're 6 feet away from me. So the idea there is that I use something where we can share screens and they can see what I'm pointing at, and if they're within range of me being able to talk to them, that's fine. Otherwise, utilize some sort of program to be able to speak with them, remotely. And in general, I like this approach because they get to use their own station. I don't mess up their station, they don't mess up my station, and they get their hanging protocols for PACS, and they can look at their reports, and they can look things up as they go, and they can even scroll through the images on their own PACS as they do it. So I kind of like this setup, even if they're in the same room, even if they're 6 feet away from me. I kind of like this setup to begin with. In terms of format, I like to give the residents an opportunity to be able to, residents and fellows, the opportunity to be able to look at the case beforehand, if at all possible, and to figure out what they see, what they don't see, what they want to say about it. The kind of these levels of commitment, one would be look at a case and then sort of think in your head what you want to say. Another one would be to put something down onto either paper or electronic format. And then a much more full commitment would be coming up with a report and figuring out, okay, whatever's in there is what I am going to commit to. There's that part of it. So if at all possible, I like to get to that point to have people have that. And I think it's really good to let people know kind of the time frame and figure out, okay, this is our time frame. This is what we're going to work with, and I think that's a good way to do it. It's really important to make sure that people understand what the expectations are. So, for example, I expect you to go through 5 cases, and then we'll sit down and read out, or what have you, whatever your expectations are. And in general, when someone's first starting out in neuroradiology, what I like to say is start out with the idea of 20 cases. So like 5 cases at a time, then read out 5 cases at a time, read out, break, middle of the day, then 5 and 5. And then of course, people sort of mature at different levels, different rates. So the idea of figuring out how someone's going to kind of move along that process and their efficiency and so on and so forth, just kind of have to work through that process and figure out where they are. So a good way to start the day, I think, is if you haven't worked with somebody before, figuring out like where they are, what their background is in terms of like, I do neuroradiology, so what their background in neuroradiology is, what their experience in neuroradiology is, what their comfort level is. When they're first starting out, never seen a head CT before, I think it's a good idea if we read out together. And then if they have a whole lot of experience and idea of like look at things and pile up some cases, let me know if there's anything we need to talk about more urgently. And then otherwise we'll read out at this particular time and go through things. And I like to sort of range it in there to figure out how much leeway I'm going to give them in terms of what the expectations are going forward. But I think good communication here is really paramount to having a good readout. In terms of resources, there are a lot of fantastic web-based resources nowadays, especially. So when I'm reading out with people, when I'm teaching at the PACS, I like to bring up a web browser and then use a search engine to, whatever topic it is, like a particular diagnosis or entity, and then go to the images tab and then figure out what some good examples are to be able to supplement like at the time learning. People usually have their own favorite resources in terms of like looking things up, and then of course, looking up the literature, as we go. But at the time learning, very helpful, and usually people have resources that they like, but that's in general how I like to do it to complement something. So for example, you get a particular diagnosis and you say, okay, let's look at a few other examples of what that diagnosis might look like. All right, if you end up giving people quote unquote homework, then it's super important to follow up on that. Don't just kind of leave it out there. If you're going to just leave it out there, just tell them, I'm not going to follow up on this. This is for you. I'm saying, I think you should do this, but I'm not going to follow up on it, so that people understand, that part of it. And then you'll see a little bit later, I'm going to mention it again, the idea of, next time you read out, build on that previous readout to say, okay, last time we touched on this, and then, last time we went over that. It can get very challenging to figure out what you taught to who and what they understood and what they didn't. So, I feel free in, sort of going back and say, I don't quite remember if we went over this before. I think that's fine, to kind of, it's better, I think, in that approach than to assume that you've covered something. I just like that approach better, just complete, or like open communication. So the next 4 slides are some topics that I just want to make sure that I impart here. And so first of all, when I'm reading out, and this is how I approach it, I make sure that it's very clear that I know that that's a real person. And I think that that connects really well to, like, when the medical students are here. I think they need to understand that I understand that certainly every time. And so I approach it with that importance every time. And I want to make sure that they understand that this is, real, healthcare, right? I try to teach on every case, even when they're normals. I try to find something to talk about. I try to find something to teach. I try to use analogies and anecdotes. Hopefully the idea there is that it'll help ground it and be easier to remember. I try to make it as clinical as possible. Try to show that I'm a clinician and that I'm part of the healthcare system, helping take care of that patient. Keeping it brief is very important because, you're going to see a lot of cases if you're anything like, me. And so the idea there is you want to keep it brief and focused and have it be useful, what you're going to do with it. As I said before, connect to your previous teaching sessions if possible. If not, totally get that. There are a lot of people and a lot of time, and over the course of time, it may be hard to remember, but I think that's good if you can do that. When I go through a case, I tell them that we may end up in a different place than we started, but they'll know my thought process the whole time. So they know how I'm thinking about it and what I'm thinking about. And I might modify how I'm thinking about it based on our dialogue, talking about it when we're doing the readout. But it's important that they understand we may end up in a different spot so they don't get confused about it. But people have responded well to that when I do it. The idea is that they'll know what I'm thinking along the way, and hopefully that will give them insight into how I approach a case, and that hopefully is useful. I like to say, when we go into the electronic medical record, I like to call this a chart biopsy. The idea is, figuring out what's already known about that patient, the diagnoses they already have, the clinical questions to answer, maybe lab values, prior results, pathology results, radiology results, and so on and so forth. So I call that the chart biopsy. I'm sure I'm not unique in that regard. But the idea is to come up with something and show them how that can be super useful. So the idea there is, if I do a good job of doing that before I start to interpret the exam, hopefully I do a better job of interpreting the exam. Sometimes you go in and you're expecting to have a finding, and there it is. So sometimes that happens. You can help them understand why that's useful. And in doing neuroradiology, I think, for example, the more neurology I know, the better neuroradiologist I'm going to be. The more neurosurgery I know, the better neuroradiologist I'm going to be, and so on and so forth. So I try to have that grounding and that preparation, and it's then how that fits together. And then of course there's the idea of, like, you go through the process and then of looking at the images, and then you figure out what you want to say about it, but then it's putting it into the clinical context. And of course that's the clinical correlation part, like, that we're not supposed to say anymore, that expression. But still the entity, the process, I think is helpful to figure out how it fits into the process. And I keep telling them I'm focused on answering the question and or finding the important findings and putting that into a clinical context of what would be hopefully helpful to that team helping take care of that patient. I approach it in a very holistic manner. I kind of think about the whole of the patient and health. And if I can make a diagnosis that has a clinical relevance, I'm going to try to do it, whether it's incidental or not. That's kind of my approach to it, and that's what I try to impart when I'm teaching. I teach them about the life cycle of the scan, from the idea of ordering it all the way through to when the report goes out, and the patient and or referring physician are able to see that report. And then there's that follow-up process. So like to think about that part. That, of course, includes performance of the examination, which a lot of times people are kind of remote from that nowadays. So I try to ask them questions around that to make sure that they understand the process and along the way. I like to focus on these four topics that I think everybody needs as a physician: quality, safety, utilization, and appropriateness. I think everybody needs that. And so I don't want to skip over that in terms of like us as a radiologist. I think that's super important what we do. And so kind of focus on that. And I try to ground it with the particular cases that we're looking at, And then in terms of like figuring out what I want to get across is the idea. I want to be of high value and I want to be of excellent service. And so those are kind of like, the little M milestones or kind of guides that I use to try to figure out what I want to do in terms of what I want people to think about my work. I have a low threshold to communicate, and I try to show them that in terms of how I do things, and to talk to people, to ask questions, to figure out what's going on, and am I answering the question that they have, or is it useful what we're finding, and can we be more specific about the results? I do modify what I do based on discussion and feedback from trainees. When I first started as an attending, I realized, doing this process, I talked about a whole lot of things and I wasn't clear about what should go in the report, what shouldn't, what's just for them, what's for the report, stuff like that. So I learned to be able to do that and modified what I do. And then I also try to summarize at the end of the readout session to make sure, if they're, if it's more than normal, I try to put that there and try to summarize at the end. So I've modified that, and then I try to let them know that their feedback will make me better, and then I read it and I try to make myself better. It's not super fun to get feedback that you're not doing a perfect job, but on the other hand, hopefully it makes you better, and that's a good process. So I try to figure out some way to make the sessions useful for everybody that's there. So sometimes I'm with a team that has people at different levels: medical student, intern, resident, fellow. I'm on a team like that. And so I try to make it useful for everybody. Try to give everybody something as we go through it. And kind of my guides are, I try to do a pearls and nuggets idea. So some take-home pearls, and then a few interesting things about it, the so-called nuggets. So that's kind of like for each case, what I try to do. And again, hopefully it'll be easy to remember, useful, helpful, those kind of things as well. So when you approach things like teaching at the PACS, of course, you want to have a plan, but be willing to modify that plan if appropriate. And then, be nimble, be able to evolve and learn from the process and learn from the feedback. And even in the same session, how it may evolve, like, okay, this person I'm reading out with, they really know all of this kind of stuff. And then, so you're just trying to figure out, okay, well, let's figure out where the holes are in their knowledge and kind of fill those holes. Maybe there's that, or maybe, I need to backtrack here and go back to first principles and really basics. And, there's that part and everything in between. I try to make the sessions interesting and fun. We work hard. The idea is hopefully if we make it interesting and fun along the way, we'll be more interested in the marathon version of staying in healthcare and avoiding things that might keep us out of healthcare. There's that part. I try to make it interactive. I try to involve the whole group so everybody's there. I try to involve them. There's that whole sort of way of putting the medical students behind you and then like ignoring them. That's not me. I try to involve them. I try to ask them questions. And then when I do that, for anybody on the team, I ask the question and I pause and give them a chance to answer, but I don't let it go for a long time and then I kind of just jump in. And so that's what I would do. And then I invite them to ask me questions and we kind of go back and forth. So there's that part as well. Summarization, encapsulation, did they get it? Again, that's something that I've learned from my feedback and that I add in at the end. And I think that's a good thing to do. over the course of time, I've realized if I don't specifically say we're talking about physics and I don't specifically say that I'm giving feedback, that they don't always understand that I'm doing that. And so I make it a point to say those words over and over when I'm doing it so that it's getting out there and it's clear and that we're doing those things. And then finally, something that I realized a few years ago is that I've known for a long time I don't know everything, but realizing that I don't know everything and embracing that is actually a very powerful thing. So it really is quite powerful. And you know, I encourage you to kind of embrace that part of it, knowing you don't know everything, and that's powerful. That's good. So I want to say thank you, and hope you enjoy teaching at the PACS.